Hi guys, our presentation is on Adalimumab for the pediatric use in Crohn's disease, and our group members were Kelsey Curlin, Marie Karam, Zara Khan, and Megan Lampkin. Our attention getter slide gives a little Taylor Swift pop culture. Crohn's disease, it's me, hi, I'm the problem, it's me. Your gut on its reputation era is moody and mysterious. The disease state definition. So according to the NIH, Crohn's disease is a chronic disease in which the abnormal reactions of the immune system cause inflammation in the digestive tract, most often in your small intestine and proximal colon. It is a form of IBD, and it affects around 1 million people in the United States. Some of the risk factors, not all, but some, are ages 20 to 29, positive family history, Jewish descent, or cigarette smoking. The pathophysiology of Crohn's is multifactorial, so it includes genetic components, infectious components, immunological, environmental components, and then also dietary triggers. And some of the things that you'll see occur in the Crohn's progression is crypt inflammation and abscess formation, granuloma formation, skip lesions, which is diseased tissue surrounded by healthy tissue, and then ulcerations, fibrosis, fistulas, and bowel obstruction. Some of the signs and symptoms of Crohn's, they can be intestinal or systemic. It is a chronic disease with a progressive course. So some of the intestinal symptoms are going to be nausea, vomiting, persistent diarrhea, sense of urgency. You can also have constipation, abdominal pain or cramping. Some systemic signs and symptoms are going to be fever, anorexia or weight loss, joint pain, swelling, skin complications, mouth sores, osteoporosis, etc. And then some of the complications, intestinally, you'll get some bowel obstruction, fistulas, abscesses, fissures, perforations, and even toxic megacolon. And then systemically, you'll see growth delays in children. You're predisposed to colon cancer. You'll see kidney stones, gallbladder or liver disease, anemia, and then also extraintestinal manifestations. There is no single diagnostic test for Crohn's. Typically, this is a diagnosis of exclusion, but you can use a combination of the following tests to help confirm your diagnosis. So that would be blood tests to check for anemia, liver function, or the presence of infections, stool studies like blood bacteria or looking for parasites. You can get a colonoscopy with a biopsy, a CT scan or MRI, or also a capsule endoscopy.
Some current clinical practice guidelines and considerations when diagnosing Crohn's patients is that ADL, which is Humira, is effective in patients who are new to biologics and ones who have previously been on them. It's used to treat moderate to severe Crohn's disease in children who are at least 6 years old. It's also used in children less than 6 years old, but that's an off-label use. Patients have to have a poor response or have any contraindications to traditional therapy, including nutritional therapy, steroid use, or immunomodulators. ADL use for pediatrics was first approved back in 2012. The dosing is based off of the patient's weight. The initial starting dose is different than the maintenance dose for the child. For children that weigh less than 40 kilograms, day 1 dose is 80 milligrams. Day 15, 40 milligrams. Day 29 is 20 milligrams, and the injection is then given every 2 weeks after that at the 20 milligram dose. For children that weigh over 40 kilograms, day 1 dose is 160 milligrams. Day 15, 80 milligrams. Day 29, 40 milligrams every 2 weeks. The first dose has to be administered in office under medical supervision so the patient can learn how to do the injections at home, and that way the parents are taught as well, and to watch for any adverse reactions and injection site reactions. The medication does have to be refrigerated as well and is injected underneath the skin. And you have to make sure that the patient and the parent are compliant because it is administered biweekly. It's also important to discuss and monitor the risk of infections, so TB, viruses, bacterial, fungal, as it is a TNF blocker and does lower your immune system. It can put you at an increased risk for cancer as well, basal cell and squamous cell, so you do have to disclose that to your patients. A TB test should be done before the initial dose is given, as well as Hep B screening, CBC, and liver function tests. Make sure the patient and parent are aware of the side effects and what to look out for. Make sure that the patient is up to date on vaccinations because no live vaccinations are allowed while the patient is on treatment. It's also important that the patient remains adherent to the injection schedule, and if they are able to self-inject, and that they're educated in the appropriate way to do so. Injections may cause a reaction at the site, so as a provider, it's important to support your patient through this difficult time, as it may impact their appearance/body image, as well as the disease that it causes itself. It also plays a role in body image. It's also an expensive drug, and so adherence is very important as well.
Adalimumab is a monoclonal antibody that's designed to recognize and attach to TNF-alpha. Once it binds to TNF-alpha, it blocks it from interacting with normal receptors on the cell, which prevents it from sending out inflammatory signals. This is done to reduce inflammation, help the gut lining heal, and relieve symptoms. Over time, it can also help prevent long-term damage to the intestines and allow for better growth and development in kids. There's an increased risk for infection with using adalimumab because it blocks TNF-alpha, making it easier for you to get sick. So you're at high risk of infections like tuberculosis or bacterial infections. There's also risk of injection site reactions, as adalimumab is given as a shot under the skin, so you can get redness, itching, swelling, or pain. There's also risk for cancer or lupus-like syndrome, and some will develop psoriasis. It's contraindicated to take with other immunosuppressants because it can suppress the immune system too much. A lot of vaccines can be dangerous to take with adalimumab because the immune system might not be strong enough to handle the weak virus.
Okay, the first study that we reviewed is combination therapy of adalimumab with an immunomodulator is not more effective than adalimumab monotherapy in children with Crohn's disease. This was a post-hoc analysis of the PAY-LOT randomized control trial. The purpose was to evaluate proactive versus reactive therapeutic drug monitoring in children with Crohn's disease that's treated with adalimumab, and assess the efficacy and safety of adalimumab combo treatment in comparison with monotherapy at week 72 after you start the adalimumab. It was a randomized open-label parallel group design over 72 weeks, and they compared two treatment groups, adalimumab monotherapy versus combo therapy with adalimumab and an immunomodulator, which was either azathioprine or methotrexate. As I previously mentioned, it was randomized open label. All participants received an open label induction regimen of adalimumab. There was a proactive and a reactive group, and then outcome measures were assessed at weeks 48 and 72. The study utilized a significance level of 0.05, but because it was a post hoc analysis, there was no power reported. Some of the inclusion criteria included ages 6 through 17, a moderate to severe Crohn's disease diagnosis, and patients had to be naive to biologic therapy, so they couldn't have taken any before. Exclusion criteria is pregnancy, renal failure, or other comorbidities associated prior treatment with adalimumab, or patients who had active abscesses, bowel perforations, small bowel obstructions, or fistulas. And then the endpoint. So the primary endpoint of the study was the proportion of patients achieving sustained corticosteroid-free remission during weeks 8 to 72. And then some of the secondary endpoints that they looked at were time to loss of response, adalimumab trough levels, and anti-drug antibody formation, and then any adverse events that occurred that were related to the therapy. And then just a few of the statistical tests they used were the chi-square test, the t-test, the Mann-Whitney-U, and the Kaplan-Meier for comparative analysis. Demographics, so there were 82 participants aged 6 to 17. The mean age was 14.3 with a deviation of 2.6 years, and then the median age was 15.6 with a deviation of 2.5 years. 29% of the participants were female versus 71% of male, and then 44 patients were in the monotherapy group and 34 patients were in the combo group.
Okay, so for the results, the first graph compares the sustained steroid-free remission rates between combination therapy with adalimumab plus an immunomodulator and adalimumab monotherapy. And as shown, 46.7% of patients achieved remission with combination therapy compared to 53.3% with monotherapy. So statistically, there are no significant difference between the groups, suggesting that adding an immunomodulator did not provide additional clinical benefit in maintaining steroid-free remission. And then the second graph, it shows a comparison of adverse event rates between the two treatment strategies, and the rates were similar, which was around 20% in both groups, with no significant increase in adverse events. which was observed when an immunomodulator was added, and this supports the safety of adalimumab monotherapy and suggests that combination therapy does not confer additional safety concerns, but it also does not offer notable advantages. So for adverse events, infections and psoriasiform dermatitis were the most common adverse events that were observed, and adverse events were actually more frequent in the monotherapy group, which was 16%, and that's compared to the combination group, which was 3%. And there were no malignancies or deaths occurred in either group during the study period, supporting the overall safety of adalimumab in children. Okay, so for conclusion and critique, combination therapy did not show additional benefits over monotherapy, with both groups having similar remission rates and no significant difference. There was slightly more adverse events that were seen in the monotherapy group, but overall the safety was good, and the strengths of the study include a large pediatric sample, RCT design, and meaningful safety data. However, limitations include lack of power calculation, potential confounders, and limited generalizability.
The goal of the study was to understand how adalimumab is processed in children and teens with moderate to severe Crohn's disease. Researchers wanted to see if there was a link between drug levels in the blood and how well patients responded to treatment. The study, called Imagine-1, was a phase 3 randomized, double-blind, multi-center clinical trial that lasted 52 weeks. All participants went through a 4-week open-label induction phase where everyone received adalimumab. After 4 weeks, participants were randomized into 2 groups for the 48-week maintenance phase, which included a standard dose group and a low dose group. So again, they were all put into the low dose group or the high dose group for the maintenance phase. It lasted 52 weeks. The significance level was less than 0.5, and there were backward elimination of covariates with the significance level as seen. Inclusion criteria were children 6 to 17 years old that had failed conventional therapy with corticosteroids or immunosuppressants. Also included patients who had lost response to infliximab, and they had diagnosis of moderate to severe Crohn's disease. Exclusion criteria included patients who received only 1 dose of adalimumab and had no or only 1 measurable adalimumab serum concentration.
Endpoints and stat analysis of the second clinical trial. Primary endpoint, clinical remission at weeks 26, and it was the PCDAI less than or equal to 10. Secondary endpoint, clinical response, ADL trough concentrations over weeks 2, 4, 16, 26, and 52. The relationship between trough levels and remission and response levels. Some stat analysis used were the Matt-Whitney test, which compared ADL concentrations in patients in remission versus patients not in remission. Threshold analysis, which was the ROC, to determine the lowest amount of ADL used associated with clinical remission or response. And logistic regression analysis, which was the relationship between ADL trough levels and clinical outcomes, the remission and response. And this one adjusted for factors like patient demographics, lab values, prior infliximab or immunosuppressant use. The demographics of this clinical case study was 189 patients were enrolled, aged 6 to 17 years old, like Megan had said. Average age was 13.6 years, average weight 45.2 kilograms. 55% were males, 44% were females. The results from this clinical trial show that patients on higher ADL serum concentration levels had an increased remission and response level. And you could see that on the second graph, the clinical remission at weeks 26 were much higher with a higher dose of ADL than on a lower dose. Adverse events. Generally, the medication was well tolerated over the year-long trial. No deaths were reported. The most common adverse events during the trial were headache, injection site reactions, and infections. Anti-adalimumab antibodies were tested due to the fact that it could decrease effectiveness of the drug and cause more side effects. 6 out of the 182 patients did have the antibodies. Even the patients with the AAA antibodies. They did have lower levels of ADL in their blood, but some did still respond to the treatments.
This study was the first to describe how adalimumab behaves in children and teens with moderate to severe Crohn's disease. Higher blood levels of adalimumab were associated with better outcomes, and certain factors like higher body weight or CRP levels were linked to faster clearance of the drug. So some strengths of this was it was the first study to discuss the pharmacokinetics of pediatric Crohn's disease with adalimumab. It had a large patient population. Some weaknesses were they couldn't establish a target adalimumab concentration that predicted clinical response or remission, and there was a wide interpatient variability in drug levels.
Okay, so for the pharmacoeconomics, one was cost offsets. So there's fewer hospitalization, surgeries, and emergency visits, as well as decreased indirect cost, such as school/work absence and caregiver burden, and another one being challenges. So there's a high upfront cost, which may limit access, insurance and coverage variability, as well as limited pediatric specific pharmacoeconomic data. And then for clinical considerations, it's effective in inducing and maintaining remission. It improves growth, quality of life, and reduces steroid dependence. Also, there's long-term reduction in complications. And then for conclusion, for efficacy, safety, and cost, for efficacy, it induces and maintains clinical remission in moderate to severe cases. It also reduces corticosteroid use and relapse rates, as well as improving growth, weight gain, and quality of life. And there's also sustained response, which is observed in long-term follow-up studies. And then for safety, it's generally well tolerated in pediatric populations. Also the injection sites, reactions in URTIs, headaches. It's rare but serious, some opportunistic infections and malignancy risk, as well as regular monitoring is required. Okay, and then for the cost, there is a high acquisition cost. It's cost effective in moderate to severe diseases, as well as potential savings from reduced hospitalization, surgeries, and steroid complications. And then lastly, biosimilars may lower future cost.
Recommendations first line, second line. ADL is considered to be a second line treatment for pediatrics with Crohn's disease. First line is corticosteroids. After that, immunomodulators and biologics are used to prevent future flare-ups and avoid long-term steroid use. With corticosteroids, there is a risk of growth impairment and the chance of being addictive and patients becoming dependent on the drug. First and second line therapy is categorized based on how severe the patient's symptoms are, extent of the disease, and how deep the ulcers are, and how they have previously responded to other treatments. It is prescribed a second line when the patient has had failed therapy with typical treatments like corticosteroids, proper nutrition therapy, and immunomodulators. In severe cases, it may be used as first-line therapy. Studies have shown that ADL improves fistula progression and also improves the growth of pediatric patients. 23.8% of children who received ADL were in fistula remission, and 28.6% had a decrease in the number of fistulas formed. ADL has shown to have long-term effects in fistula improvement in Crohn's disease. According to a study done by Matar et al., children who were on ADL treatment showed significant improvement in their weight, BMI, and linear growth. When ADL and infliximab were compared, ADL was shown to have better outcome, and it was more potent than infliximab. A clinical study was done and showed that patients that were on ADL had a 79% remission at 1 year, 54% at 5 years, while patients on infliximab had 67% remission at 1 year and 37% at 5. If patients do not want to be on a pharmacological treatment, they could always do exclusive enteral nutrition, which is a non-pharmacologic approach where patients are basically on a liquid diet.
And these are our